introduction and for the opportunity to present the results of our study, or some of the results at least, concentrating on the effect of dehydration and acidemia on the potassium content of muscle tissue in calves with neonatal diarrhea. As we have heard in several instances today, diarrhea still is a major cause of death in pre-weaned calves, and neonatal diarrhea is associated with severe dehydration and acidemia of the animal, and frequently is accompanied by hyperkalemia, which can be life-threatening. If we look at the potassium homeostasis, there's the intra and extracellular compartment, and concerning the extracellular compartment, there has been an extensive amount of research, and it is well known that both dehydration and acidemia play an important role on the extracellular potassium homeostasis, and that dehydration is the predominant factor. Concerning the intracellular potassium homeostasis, there is not as much research. There are some total balance studies suggesting or showing the depletion of intracellular potassium stores, but the mechanisms in which dehydration and acidemia affect the intracellular potassium homeostasis are not fully understood. Therefore, we formulated our hypothesis in which metabolic acidosis and dehydration both contribute to the intracellular potassium losses in calves with naturally occurring diarrhea. We therefore sampled 27 severely diarrheic calves admitted to our clinic hospital at 2 different sampling times. The first sampling time, we will call it T0, occurred directly after admission and before treatment of the animals. Calves had to be severely dehydrated, show acidemia, have naturally occurring diarrhea, be between 3 and 21 days of age, and require parenteral fluid therapy. After the first sampling time, the treatment ensued, consisting of a standardized treatment, consisting of an initial correction of the acidemia, followed by a drip infusion, which was also standardized, and accompanied by oral rehydration solution, or offering of this, and calves were kept on milk replacer. The moment calves did not require parenteral fluid therapy anymore and were capable of sustaining their acid-base homeostasis or status and their fluid homeostasis solemnly by uptake of oral rehydration solution and the feeding of milk replacer, the second sampling time occurred. Additionally, we sampled 10 healthy age-matched control animals to have values for comparison in a healthy calf. The sampling consisted of a muscle biopsy, which you can see in the picture. The diameter of the needle is about 8 millimeters, which was measured for muscle potassium content and muscle dry matter, and jugular blood samples, which were analyzed for total protein, values of D-lactate, plasma potassium concentration, and we performed a blood gas analysis. Samples were then compared to one another, so the T0 to the T1 sampling time, and to the control values. We then performed regression and correlation analysis to assess the effect of parameters associated to dehydration and/or acid-base status on the muscle potassium content, but also the effect of other factors as age, potassium intake per 24 hours, or the duration of the disease before admission. I will now come to the results. First, I would like to have a look at the acid-base status. Here we can see that calves admitted to the hospital, so that's the sampling time T0, showed a severe metabolic acidosis, and after treatment to the second sampling time, these values dramatically, significantly improved. The median time between the 2 sampling times was 60 hours. For the parameter for dehydration we chose was the total protein. We can see that between the 2 sampling times, T0 and T1, there was a pronounced decrease. It's about 15% which was indicative for us that we sufficiently or that we rehydrated the animal between sampling times. As we look at the plasma potassium concentration measured in these animals, we can see that at T0, the calves showed a wide variation of plasma potassium concentration with a tendency to be hyperkalemic. And after treatment, though this wide variation narrowed quite a bit, and there was a tendency to be hypokalemic. Associations to the plasma potassium concentration at T0 were found to the delta total protein, which was a positive association in which the higher the dehydration was, the higher the plasma potassium concentration had been at T0. And another association was found to the age at admission, which was a negative association where younger animals showed a higher plasma potassium concentration. At T1, there were no associations to parameters associated to dehydration and/or acid-base status. If we look at our main variable, the muscle potassium content, we can see, surprisingly, that between T0 and T1, so the untreated and the treated animals, there was no significant difference in muscle potassium content of the animals. Additionally, the dry matter of those two sampling times did not differ from one another. If we compare these values to the values measured in the healthy age-matched control calves, firstly, we can see that there is a larger degree of variation in the healthy control calves, but values here did also not differ from the sampled population, and also the control dry matter did not differ from the measured dry matter at T0 or T1. Associations to the sampling time T0 were found to days of sickness prior to admission, which was a negative association, showing that the longer the disease had persisted prior to the calf being admitted to the hospital, the lower the muscle potassium content at admission was measured. Changes in the muscle potassium content did not associate well to parameters associated to dehydration and/or acid-base status. So, in discussion, we did not find any differences between the muscle potassium content measured at T0 or T1 or the control animals. The literature suggests that there is a pronounced depletion of about 10 to 12% in muscle potassium content in approximately the same period of time. However, using retrospective power analysis, we could show that our sample size should have been adequate to show an effect size of about 10% difference between the two sampling times. In contrast to what is known for the plasma potassium concentration, there were no associations with hydration and/or acid-base status and the muscle potassium content. However, there seems to be an effect of the duration of the disease. It remains to be seen if this effect is specific for diarrhea or if it's something seen in anorexia and which could be associated to other diseases as well. The high degree of inter-individual variation, which was especially seen in the control animals, is something which has been shown to occur in adult cattle muscle potassium measurements. I would like to conclude that in this study, we could not reproduce the body potassium depletion of the diarrheic calf. Changes in parameters for hydration and/or acid-base status did not measurably affect the muscle potassium content. Therefore, the disturbances of the potassium homeostasis seem to primarily take place in the extracellular space, and the total body potassium depletion in diarrheic calves therefore may need to be revisited. I thank you very much for your attention, and I'm open for questions.